again, I want to thank the organizers and for inviting. Thank you, chairs. And now, as I showed in my previous one, there were multiple different ways you can do a surveillance, right? You can either choose to go through the access flow route, or you could choose to go through the pressure route. So the topic that I'll be talking now is about the ultrasound, and I'll go over why probably the ultrasound would be a good one to start getting comfortable with. There's no doubt that we need the surveillance, and the biggest advantage that I see of the ultrasound is it's not just a surveillance tool like whether it's transonic or the vascular or anything, but this is also a diagnostic tool because you can actually look at the anatomy and you can also get the hemodynamic parameters with the ultrasound. So it has that biggest advantage with it. And the other best part is the transonic or the other flow-based measurements and the vascular and the pressure-based measurements, you can use them as a surveillance tool only when the needles are in and the patient is getting the dialysis. Thank you. Is getting the dialysis. What about when the patient gets an access created and is not yet on dialysis? We are all promoting early access placement in stage 4 and stage 5, whereas the ultrasound has the advantage to do that even at that time. So the ultrasound is not something new. It was the first one to be used for this particular purpose, and it is now seeing a resurgence. And the biggest reason for that is the ultrasound has moved on from being a big, bulky instrument sitting in a dedicated room to the point of care use to as small as you can use your own smartphone with an transducer. So the accessibility and affordability has improved dramatically, making the ultrasound to be a part of your daily clinical work. As I was mentioning, you can use it even post-surgery. You don't really have to wait for 6 weeks or 12 weeks before they see the surgeon to figure out whether it is working or not. And unlike the others, you can actually get a hemodynamic assessment. Oh, and the major one now, and which this particular conference has truly showed, is you can even do interventions using the ultrasound. So that you get a complete package with the ultrasound. The biggest limitations with the ultrasound is the trained personnel. Ultrasound is not part of any kind of a residency or medical school or fellowship program unless you are in a radiology. Most of the other specialties don't pay so much close attention to the ultrasound training. So the trained personnel is probably your biggest limitations. And sometimes you may have the anatomic configurations or some local or regional limitations in performing the ultrasound. The next thing that we always have to be careful about is the source of error, because one error which gets creeped in the way you do the ultrasound, your results can be compromised or your results may become unreliable. And if you're going to use that as a surveillance tool with that error incorporated, what is going to show is that your surveillance program may not truly work out. So it's very important that we learn as to where these errors could happen and incorporate to make sure that we don't make those errors. As I was mentioning, most of these ultrasounds are being done by the technologists, and the biggest, one of the most common errors which happens is the way that you measure the stenosis, whether it is the inner wall or the intima to intima or from the outside. So there needs to be a consistency in that. And also the angle of insinuation and the Doppler angle has to be under 60 degrees. And if you make it 0 degrees or 180 degrees, kind of, you have to have a good angle. And a good angle you can provide only when you have a good hand-to-eye coordination while doing the ultrasound. And if you're doing the ultrasound for volume measurements, the way you're going to put the sample volume for the ultrasound device is very important, and it needs to be in the center of the lumen. Now, just a quick overview on what kind of features that you're going to be using in the ultrasound would be mainly the B mode to look at the lumen size and the depth and if there is a stenosis in a longitudinal view, you can measure the stenosis in both pre and post. If there is any accessory veins, you can actually see where it is taking off and what is the size relationship of the accessory vein with the relation to the main fistula. When the flow is low, you probably will use the power Doppler, but most likely you may not. But the spectral Doppler is another thing that you have to become comfortable with, not only doing it, but also interpreting it if somebody else is doing it. Among the spectral Doppler, probably the peak systolic velocity and the end diastolic velocity is the two things that you will be using. Most of the ultrasounds that you're getting these days do come as a package. Make sure that you have a pulse wave and color flow Doppler capabilities. It's a good thing to get at least one curvilinear probe and one linear probe so that you can do both. You don't really need a phased array for the access work. What are the indications on where all you could use the ultrasound as a surveillance and monitoring tool? You could use it for your vein mapping, post-creation surveillance, and if there is any dysfunctions. These will be your diagnostics. And along with your, if you are more savvy and if you're having a problem with cannulations by your dialysis techs and nurses, you could use that. And if you want to use it for the guided interventions, you could do that too. You always look at the inflow, which is your artery. In this particular figure, you have a view of, I don't have a cursor. Okay, what you're looking at is a brachial artery, which is the straight, smooth, parallel lines, and it's connected to the fistula. It's a brachiocephalic fistula that we are looking at. So you always look at the inflow artery, arterial anastomosis, juxtaanastomosis, which is the part of the vein next to the arterial anastomosis on the venous side. You want to see whether there is any blockages. You want to see if there is any turbulent flows, if there is any large collaterals, and if there is any collections, which can happen in the post-surgical or post-creation surveillance situations. So general consideration, I really cannot stress more about this, is your Doppler angle need to be good. So whenever you're going to use your ultrasound for any kind of a duplex scanning or the spectral wave analysis, make sure you're having a good angle. And those things are usually well shown up on the screen, so become comfortable with your device. So among the spectral Doppler, as I mentioned, we are looking at, unfortunately, I can't, I don't know if I can. Okay, so this is the waveform that you'll be looking at. That would be a peak systolic velocity, and that's where your end diastolic velocity would be. You can measure or estimate the volume flow using this. Resistive index is generally for if you're going to be doing a renal ultrasound, but not for the vascular axis. What's a peak systolic velocity, and what number should we be looking at is another thing, right? So the peak systolic velocity, when you measure it, generally it should be greater than around 150 in a high flow velocity, low resistant conduit, which is like a fistula, which is a well-functioning fistula where there is a very high flow and there is low resistance as long as there is no obstructions. So once you develop a stenosis, these parameters are going to change, right? In the abnormal or peak systolic velocity, if you're looking at the velocity at the arterial anastomosis, by nature, there is a lot of turbulence there. So the PSV will be on the higher end. If you're thinking about a stenosis in the arterial anastomosis, you not only look at the individual value of the PSV, but also develop a ratio. So how do you develop a ratio? So the ratio is depicted in that schematic diagram on the other side. So that's your stenosis, that's your post-stenotic segment, that's your pre-stenotic segment. So if you want to develop the PSV ratio, you divide the velocity in the stenosis by the pre-stenotic segment. It's very critical that you use that, because if you're going to use a post-stenotic, the PSV is going to be low, so your ratio is going to be very high, right? So that's not what you're looking at. You're looking at B divided by A, and that ratio should be greater than 3 if you're thinking about an arterial anastomosis stenosis, or if it's in the draining vein, should be greater than 2. And obviously luminal narrowing is 50%. So recently, the AIUM, which is the American Institute of Ultrasound and Use in Medicine, came out with some kind of a classification based upon the ultrasound parameters as to how you can classify them as below 50% and greater than 50%. And they used, I'm just going to go in the interest of time about the 50%. So at the anastomosis, you want your peak systolic velocity to be greater than 400. And in the conduit also, it could be greater than 400. And if you're going to use a ratio, it should be at least 2.5 and above. And there should be a focal lumen reduction, and the diameter or the residual diameter at the site of the stenosis generally in 2 to 3 millimeters. Because you could have a fistula which is like 12 millimeters or 18 millimeters sometimes, and then there could be a 50% reduction or stenosis that is only still 9 millimeters, right? That's still a big residual lumen for the flow to happen, so it doesn't really, it's not usually hemodynamically significant. So residual diameter is very important parameter to use. And University of Alabama in Birmingham was the first one to report using the ultrasound parameters for classifying the stenosis. Their parameters were pretty much the same, but based upon the PSV, you could say whether it is going to be 75% and above stenosed. So most of the RCTs using the ultrasound tend to go with their classification. So when you want to do the measuring the volume flow, it's very important that you pay attention to how it is calculated, because the volume flow calculations in the ultrasound assumes few parameters. That is, one, it assumes that the blood flow is minimally disturbed and it is axially symmetric at the recording site, and lumen across cross-section is circular. So you have to really, you're looking at a cylinder, not an ellipsoid cylinder or anything. So you have to be careful about these assumptions incorporated. So if you do it right with the angle of inclination less than 60 degrees, you do it in the brachial artery. Why? Brachial artery has a nice straight lumen, right? Its parallel walls are parallel, it is circular, unless you have an aneurysmal brachial artery. That's a whole different ballgame, but generally most of the healthy brachial arteries are circular. And it is assumed, or it is seen, that 90% of the flow in the brachial artery will go through your axis. So it is quite representative of your axis flow, so it's important to do it in the brachial artery. Volume-based flows, if you end up having a machine which doesn't give you calculate on its own the volume flow, you could still use the basic physics for calculating the flow, which is the average velocity times area. It's depicted on the screen. What you do is you PSV minus EDW. If you get that spectral waveform, you can still calculate the volume without need of a specialized device. So the caveats, we went over that. The diameter is extremely important. It should be measured from intima to intima. And the pulse Doppler sample size should encompass the entire lumen. That means you don't, these two parallel bars, you can't have them right in the middle and assume that that's the flow. It has to be separated to the entire lumen of the vessel. Now, ultrasound can also be used, well, not the best, but can still be used to look at the central vein stenosis if they have, just by looking at the waveforms in the subclavian and the IJs. And this particular diagram kind of helps you to identify where the blockage could be. Axis flow surveillance differs between the axis types, whether it's the fistula or the grafts. The fistulas handle the flows much low flows, but not the grafts. Generally, for the grafts, if it starts to fall below 600 and fistulas below 400, that's when you start referring them for evaluations. So there is no study for using the ultrasound criteria. There is no studies in the AV fistulas. I went over this partly in my earlier talk. One thing is for sure, it does detect the stenosis, but the current evidence, even in the grafts, does not support any kind of an improvement in the thrombosis rate. But with the fistulas, we don't have any study to make a comment about it. But as I said earlier, these data are from more than a decade ago, so we really need new studies in this regard. So the current status, the degree of stenosis alone is not, we can't assume that the stenosis always leads to thrombosis. Ultrasound is not ideal for central vein stenosis evaluation, but you could still get some information. Operator dependence is extremely important and difficult to incorporate in dialysis workflow. And with that, I stop and take any questions. Thank you.